Hello, and welcome back to our clinical case series within the Laser Assisted Regeneration module. I hope you're enjoying what you're learning so far and are ready to apply those learning concepts towards clinical cases. Do you struggle with diagnosis and treatment planning with periodontal defects in the anterior aesthetic zone, like I once did? These cases can be demanding and challenging and difficult to maintain good aesthetics post-treatment. What if I told you bone grafting and membrane was no longer the treatment of choice for periodontal defects in the anterior aesthetic zone? Instead, it should be laser assisted regeneration as your number one line of defense for managing these periodontal defects. But don't take my word for it. Let's show you a clinical case and highlight those key clinical concepts that'll show you why this treatment modality should be your treatment of choice in the anterior aesthetic zone. Let's dive in. This case was referred to me by Dr. Nathan Koo, a restorative dentist in Duarte, California. Unsure of the periodontal prognosis, he referred this case to me prior to fabrication of restorations on 8 and 9. But let me highlight a couple things on this radiograph at the time of the initial presentation in September of 2024. Look at the dark shadow, a circumferential type defect on the palatal aspect of tooth number 8. I want to highlight and I want to show you the treatment outcomes in March of 2026. Look at the osseous fill, the osseous regeneration. What if I told you this was only done with a laser regenerated blood clot using the patient's own live viable stem cells to allow for osseous regeneration? Incredible result. When I look at tooth number 8 back in September of 2024, this tooth had a guarded periodontal prognosis. No doubt about it. But with treatment, there's a possibility that I can stabilize the tooth. Now remember, I'm not saying twos and threes. I'm saying if I can bring that tooth better than what it is now, that's an improvement. How much better? We won't know until we treat this tooth clinically. But remember, I am looking at, when I look at prognosis of teeth, can I control for disease progression? That's my number one factor when I'm considering treatment and saving these teeth in the anterior aesthetic zone. The other factor that I'm looking at is mobility. Can I control for traumatic occlusions? So if I can remove the etiologies of the periodontal pathogens and the trauma from occlusion and possibly endodontic issues, which may have played a role in this case with being a combined endoperioral lesion, if we put all of those factors at play and we can control for all of those etiologic factors, we will get predictable osseous regeneration in the anterior aesthetic zone with minimal tissue shrinkage. Let's talk about a couple key learning concepts from this case before we look at clinical photos. One, I want you to be able to find the indications, case selection, and suitable defects, three-wall, two-wall defects that are narrow and deep. The more narrow and the more deep those defects, the more predictable the osseous regeneration. We also have to control for any endodontic etiologies at play. I'm going to be able to summarize the LANAP protocol. And remember, I'm going to use LANAP and laser assisted regeneration interchangeably. But I want to define those concepts right now. Laser assisted regeneration is the LANAP protocol. However, laser assisted regeneration is for site-specific areas. When I'm referring to LANAP, I'm referring to a full mouth disease protocol typically treated in one sitting. I want you to finally be able to recognize complications, limitations, and apply evidence for early detection and proper management. So let's look at the initial presentation of this case. Notice we have splinted anterior provisional restorations, but we have localized gingival inflammation on the distal buccal aspect of tooth number 8. In the periapical radiograph adjacent to the photo, you can see the periodontal defect. You can see the darkness right here on the distal aspect, but you can also see this line here if you use your imagination, right? So you have a circumferential defect extending from the buccal on the distal aspect around to the palatal aspect of tooth number 8. Again, I'm unsure of the prognosis, but remember, prognosis can change with treatment. The other thing that we want to do in terms of healing is we don't want to place any final restorations until I know how well this area has healed. With this case, we're going to treat this area using a laser assisted regeneration protocol using the LANAP protocol with the PeriLase MVP7 laser. We're going to allow this area to heal for 6 months before taking any clinical probe depths. But what are the probe depths in this case? Well, let me show you. Under local anesthetic, bone sounding probe depths are approximately 11 millimeters on the distal buccal aspect of tooth number 8. And as we move around to the palatal aspect, you can see here about 9 millimeters on the mesial palatal aspect. And as I walk that probe around the palate, we are at about 6 to 7 millimeters on the distal buccal aspect. This case brings about two important teaching points when it comes to using the PeriLase MVP7 laser. First, do we want to do non-surgical therapy in this case, SRPs, prior to laser-assisted regeneration? No. And why is that? Remember, Nd:YAG laser wavelength will be absorbed into hemoglobin and melanin. It's absorbed into pigmentation. It is absorbed into infected and inflamed tissues. So if we do SRPs and we remove the gingival inflammation, the laser will not target the tissues as well. The laser wants inflammation. The laser wants infection. The laser will work better when these conditions are such. So this brings out another teaching point. So if I have two periodontal defects, let's say there's a periodontal defect on number 9, which there isn't, but let's say there is, and let's say the tissue quality, let's say it's the same defect on 8 and 9, but the tissue on 8 is inflamed and the tissue on 9 looks healthy. What site is going to use more energy? Is it the inflamed area or is it the healthy area? It's the healthy area. You will use less energy on infected and inflamed tissues because the laser is going to work better because it's going to be selectively absorbed into those target tissues. Key learning point. Less is more with lasers. And remember, we want the tissues to be more infected and inflamed. I'll highlight this teaching concept on other clinical cases. You'll get to see the difference in terms of how much energy was used for a full mouth case. You'll be quite surprised. So now I want to highlight the LANAP protocol. And again, I want to highlight the difference between LANAP and laser assisted regeneration. Laser assisted regeneration is the LANAP protocol using the PeriLase MVP7 laser to site specific areas, and LANAP is a full mouth disease protocol. Let's walk you through the protocol step by step to highlight a couple of important details. Step A, or bone sounding probe depths. This is important because this will allow us to determine how much energy is needed for the total case. Step B, selective ablation or selective removal of the diseased tissues and the diseased epithelium on a short pulse duration. Step C, we'll do our ultrasonics, our piezo ultrasonics to remove any subgingival plaque and calculus underneath the gum line. In step D, we're going to do our blunt dissection bone biomodification. We want to make the bone bleed so we can get the body to release stem cells. In step E, we're going to change the laser setting to a hemostasis setting, so a longer pulse duration to get that good gelatinous blood clot. In step F, we're going to thin out the blood clot with compression, usually wet fingered compression. Step G, occlusal adjustment, remove any non-working interferences and prematurities. And in step H, we're going to allow things to heal for 6 months and watch that laser-generated blood clot become bone. Here are the clinical photos at 18 months. Final restorations were placed at 6 months, as a clinical evaluation of this case suggested there was healing that was occurring. The tissues were stable, the area was healthy, so we decided to proceed with final restorations. Clinical photos were again taken 1 year after that at 18 months with radiographs in clinical probe depths. This patient only wanted two new crowns. She did not want to close the space with orthodontics, an older female patient. So, given the circumstances, the final restorations were done as such. We close the space, we close the diastema, and the patient's happy. I want your eyes to be pulled away from the provisional or from the final restorations to the tissues. Look at the tissue quality and notice minimal tissue shrinkage. The one thing I have working for me in this case is a thicker biotype. That's probably one of the reasons why I did not get any tissue shrinkage in this case or any loss of papilla. But don't take my word for it. Let me probe that area. Notice the firm pressure, the blanching that you're seeing, and the area probes twos and threes. So the area is resistant to probing, which would suggest osseous regeneration apical to that free gingival margin. But let's walk around that probe and let's look at the palatal aspect. Look at how healthy that tissue is with localized 2 and 3 millimeter probe depths. A great clinical outcome and good long-term stability. So we have improved the periodontal prognosis of this tooth. Well, let's look at the radiographs one more time before I close out tonight's case. Again, that circumferential moat-like defect with a guarded periodontal prognosis presenting in September of 2024. Flashing forward using the laser assisted regeneration protocol, look at the osseous regeneration, osseous fill, 18 months post-treatment in March of 2026. An incredible result. Again, not only radiographically, but also clinically. Minimal tissue shrinkage. This is why the laser assisted regeneration protocol or LANAP should be your number one treatment modality and your number one line of defense when it comes to management of periodontal defects in the anterior aesthetic zone. Also, we need to understand etiologies at play. I think there were three etiologies at play for this case. There were the periodontal pathogens, the endodontic involvement, and the traumatic occlusion. All of these etiologies were addressed, which allowed for predictable osseous fill. So again, just wanted to highlight this case, walking you through those key clinical learning concepts, being able to define the indications for case selection and the suitable 3-wall, 2-wall defects. Again, deep and narrow defects will allow for better regeneration. I want you to summarize the LANAP and LAR protocol. And again, being able to recognize early intervention and why that is important. So thank you so much for joining in on tonight's lecture. And we look forward to seeing you for more clinical cases. Take that 3-question quiz at the end here and get those CE credits emailed to you. Thank you so much and have a great day.